That's it, right?
Hi, welcome back. Um, so I have, um, I've had Jen draft some language coming from me. And while she's putting that up, I just wanna, um,
190, we on 190?
190, we're on 190.
Oh, sorry, I didn't 3 o'clock.
Yeah, we're still on 190. We haven't finished on 190. I just want to level set that, as this bill has been winding through and as this session has been going on, there are lots of stakeholders, all the people that we've been talking to, all the, to sort of figure out what to do. And I think the general consensus has been, we need to do something. I think there's just disagreements, among the parties of what we do to get us all equally to the same destination. So I think there's general agreement that S 190 as currently configured, while there's nothing particularly bad about it. And there's great stuff in it, but the 250 cap on the QHP, I think needed a little bit more fleshing out. So I've asked Jen to draft some legislation, which is a strike law amendment.
Oh,
And so I'm putting this forward as my idea, and I'm interested in how the committee feels about it based upon all the testimony that we've heard essentially through the year. Lots of testimony. So thank you, Jen.
Sure. Good afternoon, Jen Carby from the Office of Legislative Counsel. I'm putting the language up and I believe it is on the webpage. So this is presented as a strike all, so I can show you what would change. And it starts off without any changes to the first section on reference-based pricing. The second section would change a bit. For one thing, it would not be codified. So section 2 is in the bill that came over to you, is the limitations on hospital reimbursements for qualified health plans, and putting that into statute is sort of an ongoing requirement unless and until the board sets different reference-based prices for them. This would make a change, some changes. It would keep some of the definitions, Medicare adjusted base rates, not going to include critical access hospitals, so it strikes out that reference. It adds in some new definitions with cross references to existing statute. So we have Health Benefit Association is is the statute under which VHI it exists. So it's in the Intermunicipal Insurance Association subchapter in Title 24, and it is specific to health benefit associations offering plans to educational entities, I think is what it's called. So it defines Health Benefit Association there. Hospital, I'm defining as a general hospital licensed under our hospital statutes that is not a critical access hospital. Qualified health benefit plan is our exchange plans, our QHPs. Registered carrier is a carrier that offers a QHP in the individual or small group market. So that's that definition. And a school employee has the same meaning as in Title 16 in the chapter on the Public School Employee Benefits Commission. That's where we get all of our definitions from. And it starts out by directing the Green Mountain Care Board to determine the amount of hospital spending that can be reduced for hospital fiscal year 2027.
I think you need to scroll.
I'm right here. It can be
Oh,
reduced.
I'm sorry. Sorry, my bad. Skipped ahead.
Sometimes it's.
I'm sorry, my
It's
bad.
okay. Sometimes I don't even have it up on the screen. Can be reduced for hospital fiscal year 2027 using criteria that are consistent with ongoing hospital transformation efforts and the goals set forth in last year's Act 68, without jeopardizing the sustainability of Vermont's hospitals, without reducing spending across all hospitals by more than 2.5%. In establishing fiscal year 27 hospital budget orders, it directs the board or requires the board to direct each hospital to implement its required spending reductions through limitations on the hospital's commercial reimbursement rates for qualified health benefit plans and these are the VHI plans. So, and for health benefit plans offered to school employees by a health benefit association pursuant to 24 VSA 4947, based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. So pausing here for a moment, it's basically directing the board to set, to set reference-based prices for the QHPs and VHI plans, and have the hospitals implement their spending reductions through those limitations on the rates they charge to the QHPs and the VHI plans. And then it says for hospital fiscal years after 2027, the board shall determine up to 2.5% in hospital spending reductions annually as set forth in subdivision 1A, and shall direct hospitals to implement those reductions through limitations on their commercial reimbursement rates as set forth in subdivision 1B, until such time as reference-based pricing is fully implemented in this state in accordance with the statutory provision on reference-based pricing. So it would set this up specifically for plan year hospital fiscal year 2027. It might continue on to future years if reference-based pricing has not been fully implemented. And then it prohibits a registered carrier or health benefit association from reimbursing or agreeing to reimburse a hospital more than, and here's where we're taking out the 250%, the percentage of the Medicare adjusted base rate specified by the Green Mountain Care Board pursuant to subsection B. So this is making it work on the payer side as well. For the applicable hospital fiscal year, for any item provided or service delivered in Vermont to an enrollee in a qualified health benefit plan, I should say, or a health benefit plan offered to school employees by a health benefit association.
You said there's a missing or?
Yeah.
Okay.
Leslie, did you have a question?
Well, I'm just not sure I understand, and you may go through this later, but in two, hospital fiscal years after 2027, that means that the board is limited only to a 2.5% up to increase, in reductions.
Right, they're identifying up to 2.5% in reductions and directing the hospitals to implement those through limitations on commercial rates.
Do we know where that number came from?
Actually, it came out of Act 68
Okay.
of last year. If you recall, there was we call it the carrot stick section, where we provided funds for hospitals to move ahead with transformation. And then we required AHS to bring 2.5%, reduce 2.5% hospital spending.
And it
So-
started at 10.
Yeah, it started at 10.
And then 2.5.
Yes, that's where the 2.5 came from.
And how does it mean, like, in perpetuity, or how does that work?
Well, it would continue until reference-based pricing is fully implemented in the state.
How does
Like
that
a transition.
specify? What does fully implemented mean?
When they have been.
Every charge master
Yes.
law,
Yes.
everything on the charge
Well, we
master.
asked them to do that plan
Which
they're
is
working on.
23rd, I'm sorry,
2030.
Elena, what year did we tell you had to be done with
I
reference-based
don't think
pricing?
you told them when they had to be done. You
No.
told them they're supposed to begin implementing it by this hospital fiscal year, and in 2030, I think they start doing the global hospital budgets.
So between now and global hospital budgets, then it's.
Well,
2028.
but I think all of them, that may be true. 2028 is the first global hospital budget, 2030 is all hospital. global
That's
hospital.
down for me. You're just adding VHI into the first round. Is that what this is?
Yes.
It's adding VHI to the first round. It's not picking the percentage of
Right.
Medicare for the
Yes,
reference base, but allowing the board to identify the spending and sort of back into the Medicare percentage, the percentage of Medicare based on the amount to be drawn out of the system.
So it's not the legislature trying to figure out
Right.
how much can be drawn out safely, or what the percentage is, because we've heard a great deal of concern over if you put it at 250, okay, it means this for, Blue Cross, what does it mean for MVP? How much are we really drawing out? So instead, what it does is it tells the board to determine how much they feel in their regulatory process that they already have, and for them to come up with that rate and apply it to the QHP market and the VHI. Are we done with that section, or do you want to finish that section?
And there's still some more in that section.
Can they go higher?
That hasn't changed.
Higher than 2 point? What if they want to go, I mean, in the past, they've had other,
It sounds like,
I think,
not every year's been a reduction. I'm just wondering, but we don't have to answer that now.
I don't remember what the language said that was just up there.
I will put it up in a second. I just wanted to wanted to fix the missing or in my
Oh, thank you.
document.
I just wanted to clarify something about the second part that Deb put up.
sure.
So the first part we just discussed. The second part asks the hospitals to, without the language in front of me, I'm winging this. So you don't have to put it up yet. I'm just trying to make sure I understand it. You can correct me, but like, it's asking the hospitals when they negotiate reimbursement rates with commercial insurers to keep them under a threshold. Is that what it was?
So it's basically, I was trying to do sort
Yeah.
of both sides of it. So the hospital is identifying the amount, directing the hospitals to implement the reductions through their limitations on commercial rates.
Yeah.
But also directing the carriers not to, or the payers not to reimburse or agree to reimburse
I
more
see.
than the specified
I hadn't
percent.
got to that yet. I see that. Thank you.
And then carrying over this concept from S-190 as passed by the Senate, which is if there's a reimbursement that is being done on a capitated or other non-fee-for-service basis, then just make sure that, so I'm just adding in VHI as the payer here, ensure that the reimbursement method is adjusted to account for that limit. Taking out the language about Green Mountain Care Board establishing a different reference-based price that was in with the 250 cap, still prohibiting balance billing, and then having the review of premium rates. And I wasn't sure which, I put in 8 VSA 4026 and the Intermunicipal Insurance Association subchapter, and expanded to both Green Mountain Care Board and DFR doing rate reviews and ensuring that the limitations on reimbursements are appropriately reflected in the premium rates for the QHPs and the VHI plans. That was it for that section. Section 3, I just made some conforming changes. This is in the hospital budgets and budget review. So again, instead of having the hospital implement their commercial reimbursement rate reductions ordered by the board as part of the hospital budget process through the limitations on specifically the QHPs under the statutory reference, it's limitations on the reimbursement rates for QHPs and the VHI plans, as then I said, as directed by the board.
Wait, I'm trying to digest it. It's like, let me look.
Really fast.
Okay, thank you.
And then I kept in language saying if the hospital is required by the board's budget order to reduce its commercial rates by an amount greater than what they achieved pursuant to subsection A, then they would target those rates that are more than 500% of the Medicare adjusted base rate, or if they don't have any of those, any that are whatever the highest ones are in relation to the Medicare adjusted base rate. And striking the reference here to 33 VSA 1815, because that's what we took out of statute. But otherwise saying a hospital, except as provided in the limitations we've established, a hospital may increase the rates that it charges for one or more of its service lines, such as primary care, as long as in doing so it remains compliant with its total budget order.
So let's stop there for a minute. So again, it's sort of been agreed by all payers that, you know, we need to do some, and if you remember the board, the reason that they can't start implementing reference-based pricing in hospital budget year 27 is because of the rulemaking process that they're currently going through, and we'll take them through. So that is why the legislature much like what we did with the prescription drug cap last year, we put that in place. And so I'll tell you my thinking. I think that the QHP market is the most vulnerable market. These small businesses that are in the QHP market have no other place to be. I think that they've borne the brunt of increases. You know, I mean, we just heard about the self-funded, and the self-funded have had option, and I don't want to say they've been insulated necessarily from the huge increases that we've had in spending, but I don't think it's been quite as dramatic for them. I guess is, you know, they're starting from different levels. And as we've heard everybody, it's not like we can say 250 across the board for everyone. That would be disastrous for our hospitals. We, from the day one in here, when we all went around the room on what we were talking about and what we wanted to concentrate on, we talked about affordability for Vermonters. And I think by extending early reference-based pricing, allowing the board in their expertise and purview over hospitals, hospital budgets, insurance rate review, that we allow them and give them the flexibility to design and calculate the savings. And all we're saying is for the first couple years, we'd like you to make, until you finish reference-based pricing, which will benefit everybody, all markets, well, not Medicare and Medicaid, but you get the gist. That you concentrate it on these two vulnerable markets. These are taxpayers, property taxpayers, with education spending. It will lower education spending. And it also concentrates on the small group and the individual market, where I want to remind everybody. Yes. Housing endorsement for the trade. I want to remind everybody that a plan that last year, a family plan that you might have paid 13,000 for your family is currently, you would be paying 53,000 for. So that's why this language is here. Leslie and then Brian.
This is really great. Curious to know, what you might imagine the time, let me talk about property taxes and that, and those numbers. When will this bill, let's say we pass it, would have an impact?
January 1st, 2027 or October 1st, 2026. I'm looking to the board.
Yeah, like this.
Major hospital order.
Yeah.
Share the view about careful.
Yeah,
If this were to pass,
Mhm.
it would be reflected. Back up. So last year's Act 68 with the drug price cap took effect immediately. We saw an immediate reduction in that year's rates. This one has the board making a determination as to how much money there is. So it wouldn't be reflected in the rates unless we had some sort of anticipation as to where the board might go. However, you can actually put it in a condition where you ask the insurer to come back, should we do this? It might be complicated, but I think it's probably doable with Roger Blue Cross later. But I think the financial impact would be 20%.
So school budgets for
School budgets,
2027, 2028, 2028.
we don't do school budgets.
No, but we vote for them in March. Yeah, they develop it in January of 28.
Well, it would help them build back their reserves.
And it would lower the prices of the hospitals before the insurance premiums get affected too, wouldn't it?
I'd be curious to know that kind of time.
Wouldn't it affect the hospital budgets first?
Correct.
Yeah, so the hospital prices will be lower before the premiums go down. So it's like the impact rolls out over time. What I like about this is it's like you're building a better ramp onto the reference-based pricing freeway.
I love
This is
that.
like a better designed ramp onto the freeway.
And I want to remind everyone that the VHI plan, typically, most of them have high deductibles that are through and funded through an HRA. So January 27th, it would immediately reduce out-of-pocket costs, which in turn would reduce, so they would see savings immediately just because of
They,
schools.
The employees, the
well, no, I'm not
beneficiaries.
thinking about employee, I'm thinking about taxpayer.
Taxpayers.
They are taxpayers.
Because taxpayers are funding those HRAs.
Well, true.
I had some, did you make?
My comment, I threw it in there. It was that ramp analogy.
Oh,
I like
love
this.
it.
Yeah, I like
Glad
this.
it-
I like where we're
Love
going.
it.
Use the choo-choo train.
We're on a
Yeah.
reference-based pricing highway.
I just had a quick question for you.
I have Dave first.
Okay.
Um,
I have David, then you.
it's gonna put more pressure on the hospitals. I know you're probably not the right person to be
Right
asking, but
behind you.
it's a concern.
Well, it is a concern, which is actually why I took out anything to, that the legislature is doing that. It's the board, and the board is going to be putting pressure on the hospitals anyways in their rate review. This just gives them a mechanism where we can target that to these groups. So nothing we do here or in this bill is going to insulate. Well, actually, no. If we did what is currently in 190, a 250% cap, that would have the effect of us
Yes.
hurting hospitals.
So whether.
This puts it on the board to figure out what can they do that won't hurt hospitals. And then using this form of reference-based pricing to enforce their budget orders. Okay? Oh, wait, Karen.
It's sort of related. When you think about delegating the expertise and authority to the Green Mountain Care Board, do you envision that the reference-based pricing would be uniform across the board? Does it necessarily work that way? Or can it be calibrated, to different hospital?
Well, reference-based pricing that we currently have, that we are moving towards, that the board is working on, they have the ability to develop it in any way they wish. They have flexibility. It could be targeted to each individual hospital. The thoughts around reference-based pricing when we did it last year was that it's done in concert with the healthcare strategic plan that is for hospitals and hospital transformation, in trying to incentivize hospitals to do the services that their communities need, and so that they're receiving the money for those services rather than others. So the board has enormous flexibility on how they design it, which is why it takes them time. Go ahead.
One comment to answer the question, will it hurt hospitals? Anytime there's less money to hospitals, it can hurt hospitals. At the same time, what we're seeing with the drop in insured lives, that also hurts hospitals. Fewer lives that are insured hurts hospitals. As the prices go up, it hurts hospitals too. I think as I'm reading this, the balance is really hard to strike. You're either hurting hospitals by charging too much, you're hurting by charging too little, you're hurting the people who pay the insurance, you're hurting the taxpayer, you're hurting the non-hospital, like there's just hurt everywhere. It's really quite the challenge everywhere. So I think the goal of this, with the language about consistent with transformation, is important because we know transformation is going on, especially the input that we could take in considering where to go.
You know, there's the hospital transformation plan, which is what, 2 years out or whatever, right?
There's transformation going on right now. I don't think.
In individual hospitals.
Yes, 2
Yes.
years out is the healthcare delivery strategic plan.
Okay.
There is no transformation date.
That's too bad.
Yes, it is, Dave, actually.
Thank you.
Not too late to add one.
Brian, and then I want to, we are,
I wrote it down so I can be
Okay,
focused,
I
that the way
know.
I'm seeing this, and so I can be corrected if I'm misunderstanding this, but sometimes it helps to like repeat it back and make sure I understand it, and I think it actually helps others understand it sometimes, that we're increasing the amount of patients impacted by this policy decision, because we're expanding the pool that we're gonna apply the reference-based pricing to. We are, I think, protecting the providers more because we're empowering the Green Mountain Care Board to work with them to determine the right rate. So we're not forcing a rate on them based on the limited knowledge we have. We're giving them time and space to work that out. So I feel like that's a benefit. And I think that it's, what I'm hearing is that as the price goes down, utilization may go up because people are avoiding utilization because the price is high. So there might be a way that Green Mountain Care Board and the hospitals can figure that out. And I think that's Green Mountain Care Board's job. And I'm glad that they seem up to the task. And then the last thing is that I like about this, well, that's the last thing I'm going to say that I like about it, is that I feel like we're empowering the payers and the providers to negotiate a better deal for the patients and for the state versus imposing it on them. We're kind of, like we're asking them to do something, but we're not just like locking them into it. I like that there's a negotiation aspect, and I believe that in good faith, they can improve things. So I think this is an improvement to the bill. I'm excited that you had Jen write it.
I'm not sure there's a negotiation aspect. That's the only piece I want to.
Can you clarify that?
I think the amount is determined, the percentage of Medicare is determined by the Green Mountain Care Board and applied by the payers and providers.
Is that's the part where it talks about them setting the reimbursement rates?
Well, it says
I do want to understand it properly. So if I'm not, it would be good for you to clarify.
I don't believe there is a negotiation. I just want to be.
can I, like, in a really basic kind of way, explain how, so let's say the Green Mountain Care Board says, we think comfortably we can remove $50 million from the system. The Green Mountain Care Board will make an assessment on where they've set the cap for these two markets that will draw 50 million out of the system, the hospital system. And it could be, they'll say, oh, well, this year we're going to do 400%. And then next year they can say, we feel as though another 50 million can safely be done. And they can say, we're going to reduce it to 300%. So they're using the reference-based pricing on these two markets as the tool to bring money out of the system that they determine is I keep using the word safe, but I don't want to say safe, in their estimation, reasonable.
I think you're right that it is a cap.
Yeah,
So it's possible there could be a negotiation that results in a lesser payment.
that's what I was meaning, is like the prices of the specific services, there may be some negotiation on that, but maybe I'm wrong.
But they're gonna have a cap. I mean, so
Yeah.
throughout it, it's the limitation on the rates, based on a percentage of the Medicare adjusted base rate. It is,
We don't want to lose those two out of the way. Maybe not. Yeah.
Really work.
Yeah, we can-
it's prohibiting the payers from reimbursing or agreeing to reimburse more than those rates. But I don't know that realistically it's going to result in a big negotiation. They'll be negotiating, below the cap to the extent.
That's what I was thinking. It's like, this is a problem. What I was getting at is like, the Green Mountain Care Board sets a limit, but are we giving the carriers and the hospitals the freedom to say, is this price gonna be $10 or $15 and this one gonna be 10 or 15, and like kind of determine how they set the rates under the cap? That's what I was getting at.
Well, they're setting a reference-based price for each item and service.
Yeah, it has to be a specific percentage set by the Green Mountain Care Board.
Well, it's a limitation on rates based on a percentage of Medicare, so, or that the Medicare adjusted base rate. So I think technically it is a cap. I just don't know how much actual negotiation there will be. But I've not been involved in those, so I should stop opining.
I don't need to belabor the point. I think it's good,
It would
even
be
if I
a
don't
cap.
fully understand it.
I mean, if right now they pay under that, it's not like you would go up to that. It's a cap. You cannot go above this.
Yeah,
Okay.
we're tightening the belt.
Did I see another hand? I don't remember.
You want to?
Living with it.
Yeah, we need to continue.
All right.
So late.
Now we have some additional
I'm sorry.
cost containment and health benefit plans for school employees. So these are two new sections, section 4 and 4A. Section 4 amends the public school employee benefit commission duties, where they, under current law, determine the amount of participating employees' calendar year out-of-pocket expenses for which the school employer and participating employees will be responsible, and whether the school employers will establish a health reimbursement arrangement, HRA, health savings account, HSA, both or neither, for their participating employees. This would add language saying, provided, however, that the actuarial value of any health benefit plan offered to school employees, inclusive of any out-of-pocket expenses for which the school employer is responsible, shall not exceed that of the qualified health benefit plan with the highest actuarial value offered through the exchange in accordance with the exchange subchapter. It also strikes language giving the commission the discretion to determine the extent to which the employer or employee will bear first dollar responsibility for out-of-pocket expenses if using a health reimbursement arrangement, to require participating employees to bear first dollar responsibility. It does still give the commission the authority over whether the balance in an HRA would roll over from year to year. Under existing law, directs the commission to, or allows the commission to make recommendations regarding the health benefit plan design to VHI, to any intermunicipal insurance association that offers health benefit plans to entities providing educational services. My understanding is we just have one, that's VHI. And it would direct them to coordinate with the association or associations to ensure that the actuarial value of the plans complies with the requirements in subdivision B1. And then similar language would go into that VHI statute, the health benefit plans offered to entities providing educational services in Title 24, where it requires the Health Benefit Association to solicit the input of the Commission on Public School Employee Health Benefits on the design of the health benefit plan or plans to be offered to school employers for coverage of their school employees. It would require them to coordinate with the Commission to ensure that, as specified in that provision in the last section, the actuarial value of the plan or plans, inclusive of any out-of-pocket expenses for which the school employer is responsible, do not exceed that of the qualified health benefit plan with the highest actuarial value offered through the exchange. Struck the report on implementation of reference-based pricing for certain public employee health plans.
So obviously we will get more testimony on this. I included this based upon the testimony that we heard just the other day, plus testimony that we took last year on the plans. And, you know, it's often suggested that we do reference-based pricing as a pilot and relegate it to VHI. And essentially what this bill with the reference-based pricing piece of it, it extends this early adoption of reference-based pricing to VHI. However, I think we heard the other day that their current plan has an actuarial value of between 96 and 97. And this would essentially make it, and they said that they are starting negotiations and starting planning for the 2029 year.
So this would take effect.
This would take effect
Year
in 2029. So this would be for their next iteration of design, that it be lowered that it could not exceed highest actuarial value on the exchange, which I believe currently is 90.
So under.
But it
Yes,
changes.
Well, right, because there's the potential 90 is the platinum, but there's a plus or minus 2%, I think, on all plans except bronze, which has a broader one. So it could be as high as 92%.
Right.
So the first sections of this, I still enthusiastically support. This part, I think we need to hear more about labor law and make sure that we're not going too far into the process of negotiations.
Because you're applying this prospectively for contracts that have not been negotiated, I don't believe there's a problem. I have run it by my colleague who handles labor.
That was exactly my question.
We can hear from witnesses and figure it out, but that's my.
Sure, yeah.
Jen thought of that, because Jen thinks of everything.
Thank you for thinking of it.
How many lines are we talking about for Beehive?
There's about 20,000. I looked it up.
Okay.
I looked it up oh, it's more now? Okay, sorry. Old news.
40 families and 35.
I might have missed the category then. I was trying to add them all together on my computer earlier.
Leslie?
That was my question. How did it affect our established contracts and going forward?
That's why the timing is what it is.
Oh, I have one other quick question.
Yeah.
Just, if you don't know it, another person in the room might, considering all the brains in here right now, but, I'm not being sarcastic. One of you has to know this, like, if not, I'll be shocked. It's how many lives are in the QHP market?
That's a Mike Fisher question.
70,000?
30-ish thousand in the small group, and maybe it's down to 28 individual.
So about 58,000?
Was 70, so yeah.
So what I'm getting at is that we could potentially affect like 90,000 lives. That's almost a sixth of the state with this action. And that's pretty significant. I'm just acknowledging that feels meaningful to me, that many people would be quickly impacted. Well, maybe not quickly, but in the grand scheme of government, quickly.
I think, largely I was thinking, again, we keep talking about affordability and while, yes, obviously educators contribute to their health plan, that is taxpayers paying for that. So property taxpayers and other taxpayers. Okay, shall we go?
Keep going? Yep.
Yeah.
All right. There. So as I mentioned, it would strike out this report on implementation of reference-based pricing for certain public employee health plans. And report back. Then no changes to the next several sections. So no changes in hospital outsourcing, the healthcare professional bargaining groups, sales agreement and care board orders, or data infrastructure. It would strike the Public Employee Health Benefit Authority Study Committee. In the next several pages, and I don't know if you want to speak to that.
This was the section 10. To be honest with you, the original amount appropriated for this, I think, was Nolan put 30 to 50 because they hadn't gotten back to. But the treasurer came back that it would be 350,000 for them to do this, and we
Yep.
don't have $350,000.
That's me, though.
Brian,
I support taking this out for next, because if we do reference-based pricing, right, this may be irrelevant. And I just feel like we have enough studies going on right now. There's only the capacity, we're hitting the threshold. I've seen us do too many studies in 10 years that we don't even look at, or, well, I don't want to be that dismissive. We look at it and then we look at them. Some of us read it carefully, some of us fight for it, others don't. But I don't feel like we do what the studies say a lot of the time, so I'd rather not waste money on it. Not to be harsh, but I think it was a good move.
Thanks.
Last couple pages, and then there are changes in the last section as well. So this is the critical access hospitals and Medicare outpatient cost sharing. So it starts out by acknowledging that the General Assembly and the Green Mountain Care Board have recently become aware of a federal requirement that Medicare beneficiaries must bear financial responsibility for 20% of the amount charged for outpatient services delivered by critical access hospitals, not 20% of the amount that Medicare pays for the service. While the General Assembly understands that it cannot invalidate this federal requirement, it also recognizes that this requirement has a significant, unfair, and negative financial impact on Medicare beneficiaries in the state's most rural communities, and that Vermont's critical access hospitals are some of the state's most financially vulnerable healthcare facilities. Expresses the intent of this section to begin to provide some relief for Vermont seniors and other Medicare beneficiaries from the consequences of the federal requirement promptly, while a working group of interested stakeholders endeavors to develop appropriate and enduring solutions that do not undermine the financial sustainability of our critical access hospitals. It has by September 1st of this year, each critical access hospital identifying all the outpatient services for which the amount that the hospital charges equals 5 or more times Medicare allowed amount for that service. And for each outpatient service identified, the hospital shall reduce its charge for that service in hospital fiscal year 2027 to be less than or equal to 5 times the Medicare allowed amount. It then says that to the extent that the Green Mountain Care Board engages in efforts to address the Medicare outpatient cost sharing issue in hospital fiscal year 2027, the board shall consider any proposals from the critical access hospitals and other interested stakeholders and shall ensure that its actions are consistent with ongoing hospital transformation efforts and the principles for healthcare reform expressed in statute. And it gets rid of this working group. It's my understanding there is a non-legislatively created working group happening now. And it takes out the report back and the prohibition on the board taking steps to address.
So the thoughts behind this, I will say, this is the cost sharing issue that we've heard about. While this does not address it, we heard about those extreme outliers in which when a patient, it's not going to get to the cost share where they're paying 40 some or 50 some or 60 some or even 90 some. But there were those extreme instances where if the price was more than 5 times what the cost of care was, then the patient would actually end up paying more than 100%. And that money is returned to the federal government. So it makes it so that no patient cost share would ever be more than 100%. It's not perfect, but working groups are working on it. And I just want to remind, in the first section on reference-based pricing, critical access hospitals are exempt from that QHP and VHI thing. And so I thought, okay, people are looking at it, but can we at least this year, identify just the truly egregious examples and at least reduce them so that people are not paying more money and that money is just going to Medicare. I've got Leslie, and then
I'm just curious to know where the 5 times came from and what that amounts to.
it has to do with the 20%, and if it's 2 times, then the person would pay 40%. If it's 3 times, the person would pay 60%. If it's 4 times, the person would pay 80. Yes, and then at 5 times, they would be paying 100%. But there are cases where sometimes it is 6 times, and so the person would be paying 120%. And the critical access hospital doesn't even get that 20%.
No, I get that piece.
Okay,
I'm
so
just,
that's where the 5 times comes from.
Just wondering if 5 times is the right number. What is the right
It's a
number?
first step. That's why I put it in. But we can argue, or not argue, but we can discuss.
Yeah, I'm just curious
Other
to know
numbers.
if there's a better number. Is there a more, a fairer number or not? Maybe this is the best number ever. Is there a fairer number? I don't know that.
I think that this is year one and the working group, what is the language that essentially figure out?
So developing appropriate and enduring solutions.
Yes.
Don't undermine the financial.
No, I get that piece and that's great. But I'm just thinking about the people that in the meantime are paying that, to the critical access hospitals, that 5 times amount. That's, I don't know how many people, I don't know what that amount is. It'll be different for different procedures, I'm sure, or whatever it is, but
And I
it
think
seems like a lot.
I think the intent language we put in there, understanding that we have some critical access hospitals that are financially vulnerable.
True.
It was-
But once again, the problem is our rural Medicare payers responsible for that.
This
doesn't mean-
this doesn't mean that the Green Mountain Care Board isn't going to go through their regular hospital budget process.
Right, it strikes the language saying they cannot, and it just says to the extent that they do undertake additional efforts this year, they must consider proposals from the critical access hospitals and other interested stakeholders and make sure they're being consistent with hospital transformation and the principles for healthcare reform.
So they could say not 5 times, they could say less than 5 times. Is that what you're saying?
I think they regulate hospital budgets. So to the extent that that authority flows through to additional directives they give to the hospitals and what they charge, yes.
I guess because they're just identifying at that point.
They're identifying and then they're reducing their charges for all of those to 5 times.
So 5 times.
The board may do other things.
This is, I'm just going to say, this section is just around this issue. It doesn't mean that the Green Mountain Care Board isn't doing their regular hospital.
I understand that. Yep. I'm not dumb. I mean, it's just, we're thinking about that section and that was the section 11 that came previously and now here's a new version and it's still addressing the Medicare critical access hospital problem. I get that.
So maybe there's a witness we can ask about the number 5 and get their opinion as we take further testimony.
All right,
So
so
just as far as the effective dates, most of it would still take effect on passage. The changes to the health benefit plans for school employees in sections 4 and 4A would be applicable for plan year 2029 and thereafter. And if you make changes to the contents of the bill, we may want to update the title accordingly, since it currently refers to the Public Employee Health Benefit Authority.
Or you can change the name, is that what you just said?
That's what I'm flagging here,
Okay,
that we will need to figure out what that is once we know what all is going in the bill.
can we come up with something really creative?
no.
Really rather.
Some committees do.
So can I get general thoughts from the committee on either general support on whether I'm just putting this forward. So we haven't done anything to the bill yet. This is a proposal for a strike all amendment. And I just wondered if anyone had general thoughts on this compared to what we currently have. And how do people feel about these things that Jen's just read to us? Here.
I am very, very grateful to you and anyone else that has thought this through in this way. It's a wonderful improvement. I'm very supportive of this work and I appreciate whoever was involved with it. It's great.
Yep, go ahead.
I was worried about this part of it because it felt like we owed it to the public to speak on this. And I am
Part of it.
Yeah, what part were you talking about?
the disparage in the reimbursement with Medicare. And I like it. I know that Green Mountain Care Board is working on it. So my only question about this is, this is directly to you, Alyssa, because you are somebody who did the charge master thing. How are we gonna identify the people who are not getting charged correctly?
they know what their charge is and they know what their
So there's an easy way to do this. I just
allowed
don't want-
Medicare costs. And these are, remember, these are only outpatient because this only affects outpatient.
Yeah.
So it's only on outpatient charges.
Yeah, okay, I just don't want it to be an administrative burden to, okay. That was it.
I would say that all hospitals and all healthcare facilities should be evaluating all their charges all the time, but, you know, okay.
Yes.
Any other thoughts on this? Yeah, go ahead.
My last one,
Yeah.
again, I'm concerned about the hospitals. I don't want to put too much pressure on them. I know it's up to 2.5%, but that's a lot. You know, the Green Mountain Care Board, I'm sure, is going to look at it closely. But is it possible for us to hear from the hospital one more time on whether they can?
That was gonna
And
be,
this-
okay, so that was gonna be my next question. Did anyone have any other thoughts? Yeah, Brian.
So I support the reference-based pricing piece. I said that already. And I think my understanding is that the percentage that we're saying is the highest they will go, and that Green Mountain Care will have the freedom to go low. They can go, they can do 0.01%. That's what's safe. They determine that. And we're not gonna meddle, which we were meddling in the previous one more. So I think that's a straight, so that's why I like that. And I like that we expand the pool. I'm not convinced. It's not that I don't believe Jen, but I had a union person, I'll just be transparent, text me with concerns about collective bargaining. So if any union is reaching out to me with that, I think we at least need to hear more testimony before we move forward with that piece around the actuarial value piece. So that's what I would ask for, is that we hear from the unions and maybe from our alleged counsel who Jen consulted with, and like get a few perspectives on that before we make that decision. That's my feedback. But other than that, I think that the Medicare part, I want to respect Leslie's concern about why we're choosing the number 5 and maybe hear about that, but I like the idea. Thank you. I
Great.
tried to be clear.
And that's perfect for me to be able to say, if you think we're not gonna take any testimony on this, you can think again. However, we are running out of.
Yeah, we
time.
are.
So instead of me sitting around saying, did we talk to this person? Did we talk to that person? I'm asking anybody listening or anybody in the room, get on the list, and we're gonna get you on the list, and we want to hear from you. We want to hear from everybody who this affects. Absolutely.
Like, this is their
and
notice.
The right people. Here's your notice.
Last call for testimony.
So it would just help us out with planning if you would come to us and tell us. I am going to, since Jen's sitting there, I'm gonna have Jen walk us through some language on S64.
Don't push me back to another.
I was gonna have the language of that Jen, I'm gonna have her introduce that. I wanted to talk about that, see how far we got. I will tell I'm sorry, I don't think we can get to a vote today, but Jen is with us tomorrow at 9, and we can push 197, which we have on our current agenda, and we will put S64 on the current agenda. I mean, the agenda for tomorrow morning at 9 a.m. Is that,
So I think you're not hearing from me.
what's that?
I think you're not hearing from me.
I'm gonna see how far we can get. But yeah, I don't think so, because we have a hard stop at, seriously, like 4:25, 4:30, because
Which is in 17 minutes.
so Jen, and I'm trying to,
Are we doing S64? Is that what I heard?
yes.
Okay.
So this is, Jen has prepared 2 amendments. One is around what we were talking about with the spa. State plan amendment, because we did learn in the course of this that getting a state plan amendment wasn't in the bill that came over from the Senate, and Ashley Berliner testified, so Jen has done some language with that. And then I also have some language which Tasha will post, and we can talk about that. And then obviously tomorrow, that'll give us something to think about overnight.
We don't have plenty to think about. Nothing like that. Is it me or is it getting moist in here?
Interested parties around the room, because I'm not sure because I'm not following, but has House GovOps put all the testimony on this yet? Oh, that's right, because that's one of the reasons you can't be with us, because you're in GovOps. Oh, just to let you know, this bill has to go to GovOps, but GovOps has already started taking testimony on it, so, or they're starting their testimony, so it's not like they're waiting for this to go through the, go on notice and then get referred, that sort of thing.
But it could die in GovOps if we don't get it.
And they're able to do that, by the way, because they actually have a bill on their, a companion bill on the wall, so they're taking testimony on that bill. Yeah, go ahead.
Okay. Put up the Word version for now. This is S64, an act relating to amendments to the scope of practice for optometrists. It would strike out the effective date section and then put that and 2 new sections in. So section 6 would become a new provision in Title 33 in the Medicaid chapter on Medicaid coverage for services delivered by an optometrist holding an advanced therapeutic procedure specialty. This would direct Vermont Medicaid to cover services that are within the scope of an optometrist holding an advanced therapeutic procedure specialty issued pursuant to the new subchapter in the bill, to the same extent that the services would be covered if they were delivered by a physician licensed under either of our physician licensure statutes. So by effectively by an ophthalmologist. Section 7 directs the Department of Vermont Health Access to seek a state plan amendment from the Centers for Medicare and Medicaid Services to take effect on July 1st, 2028, which is when the specialty takes effect, to allow Vermont's Medicaid program to provide coverage for services delivered by an optometrist who is a Medicaid participating provider and holds an advanced therapeutic procedure specialty as set forth in the new section as added by this act. And then we have the effective dates. So the Medicaid coverage, the state plan amendment section would take effect on passage. Section 6, which is the Medicaid coverage itself, would take effect on the later of July 1st, 2028, or approval of the state plan amendment requested pursuant to Section 7. The remaining sections would still take effect on July 1st, 2028.
Yeah, okay, Casey.
This might be a stupid question, but why do we need legislation for these two things? Because we do spas all the time and they don't all run through this committee.
There's not, so in this case, if we want Medicaid to cover these services, they are not currently covered. So we would be directing coverage of them. And in order to get coverage, we would have to amend the state plan. So in my mind, it's almost less about specifically legislating the state plan as it is the coverage. Without this, Medicaid does not cover these services by an optometrist, right? Because of the limitations of the state plan amendment. That's my understanding from Ashton's testimony. And I don't know the extent to which we amend the state plan, but often we amend it to reflect changes in legislation.
I think we do it often, so I'm just trying to understand that process better. I think we run all of them.
I just feel like every time we've expanded any sort of coverage to Medicaid, we always have the little state plan amendment.
Yes, when we're asking that, usually when we're asking them to cover something new, or if we're looking to get federal financial participation for something, we may look to amend the global commitment demonstration, which we don't need to do that here because it's a covered service. It's just not a covered service by this provider.
Can the governor's office change this state plan?
I mean, the executive branch,
Executive branch can?
yes, they're the ones who apply for
So it doesn't necessarily have to go through the legislature, it could go through.
Not everything needs to
branch.
go, but no, it wouldn't have to go through the legislature. I suppose it wouldn't have to go through the legislature if that was a was something that the executive branch was interested in pursuing as a policy on their own.
Who else can change the state plan?
It really has, I mean, the Agency of Human Services is the single state agency for Medicaid, so they are the ones who can change the state plan and through them, Department of Vermont Health Access.
Can the federal government also change the state plan on us?
We don't know.
Depends what's on the page.
That wouldn't be our state plan.
Well, I mean, a state plan is I believe is our agreement with the federal
Yeah.
government for how we implement our Medicaid program. So I don't know if they can unilaterally change our state plan, but they can change policies that have the effect
That's
of
what I was getting at.
negating things that are, or change,
Like, for example, they could say Medicaid cannot cover gender affirming healthcare, and even if it's in our state plan, if they do that, then our state plan can't cover it.
our state plan cannot override
Yeah,
federal law.
that's what I thought. So that's the power they have then, is they could change federal law and it would affect our state law.
Yes,
Okay.
that's fair.
Thank
So
you.
this is just to ensure that we move forward with coverage of these services and that the SPA is initiated, regardless of what the executive branch or the Medicaid office prioritizes. We're making sure that there is a timeline for coverage of these services with this amendment, correct?
Yes, and that they will be covered by Medicaid. Without legislation, they are not covered now, and there would be no requirement that they be covered.
I see another.
If this is covered in other states, why do we need it specifically for Vermont?
Because we do not cover it per our state. Our Medicaid state plan does not include coverage of
So every
advanced therapeutic
individual-
procedures performed by optometrists.
So each individual state
Has their own state plan.
Yeah.
What was it, 700 and how many pages when you were
Yeah,
looking
something
at
like
it?
that.
Wait,
If
that's-
you remember when we were working last year, for those of you who were here on the freestanding birth centers, I looked in our Medicaid state plan and you could see that there was an X saying we did not cover services provided at a birth center because we didn't have any birth centers. So that was something that needed to be amended to reflect that change in the state's policy.
Alan?
If you wanted Medicaid. So
Someone correct me if I'm wrong, but if we vote on this amendment and it passes this committee, then it goes where?
It's adding sections 6 and 7 to
But
the,
what happens to the bill?
Yeah.
I mean, I'm not sure if it is going officially to GovOps or if it is going unofficially to GovOps and officially to Ways and Means.
So
I think the clerk is.
we do this,
going to.
But it doesn't, I mean, it's going to Ways and Means anyway.
okay, so then that's gonna take time. Then it goes back to the Senate.
Go back to the Senate as amended.
This bill will be dead, and I've had too many friends and people at home who want to see this pass.
Okay, well, it has to go to Ways and Means anyways. And I assure you, it has to go to GovOps.
Yeah.
Betsy Ann is not sending it to GovOps because they
The
are
Senate
the Office
passed
of
this
Professional Regulation.
27-3,
Yes.
and we're trying to amend it.
As it
We're
came
trying,
from,
we're trying to get Medicaid coverage.
as it came from the Senate, it is the epitome of that wall behind you.
But this strengthens that because it
But
ensures.
it won't
coverage.
go anywhere,
Why?
because it will have to go back to the Senate and it will get stuck on the wall. We need to pass it as is. So we can get this. There's one optometrist in the Northeast Kingdom. We need this bill. We need this bill as it is. The governor can add Medicare.
Oh, I see your point. Like
Yeah.
AHS can do it.
They
Yeah.
can do it. We
Yeah.
don't have to tell them to.
I think I hear you. You're saying like if we amend it, it's gonna kill it because if we pass it as is, it'll just pass. I see your
Right.
point. I see your point. All right.
I want to ask Ashley, I don't know the extent to which they do or do not need to be directed by the legislature
To
Do a spot.
have.
to require Medicaid coverage.
Coverage.
But it could be delayed a year.
It's already 20 what?
2028.
Right, but we could do that in the meantime.
We could do that next year, the
Yeah.
same plan thing. Let's pass this so they can get moving.
Right.
Yeah, I
Yeah.
hear your point.
Is that a possibility? No, I'm just wondering.
Moving like the
bill.
Medicaid coverage? Well, you'd have to put a bill in next year.
Right.
Or tack it onto an omnibus
Somebody
bill,
would.
a Viva bill, you know.
Yeah,
Or-
We could stick it on
Or
six,
ask
seven.
them.
Yeah. 6, 7, sorry. The kids are rubbing off on me. But 6, 11's a vehicle, or we can do it next year, or we can put it in the budget like everything else that people sneak in.
Yeah, let's just get stuff out of here. I don't care.
All
That's
right,
the most passionate I've seen you yet, I appreciate it.
so no one wants to.
Something I know about.
Yeah.
Nobody wants to add this amendment to it, so we're not gonna have Medicaid coverage of it.
I wouldn't say I don't want to, I would say I'm honoring the concern that it'll kill it if it gets delayed.
I would say that we request either from the executive branch, and I don't know how exactly that works, or AHS to include it in Medicaid, and it is covered.
This isn't gonna go in effect till 2028. We can put a bill in
That's right.
next year upon passage and it'd be ready to
That's
go.
right. But in the meantime, OPR and others can get moving, so that's why I hear your point 100% now that. No, but you articulated it clearly.
I need to say it loud.
No, you articulated it clearly, and and it was shocking to me to learn you only have one optometrist available to your constituents, like that's not fair. Oops. It's a really bad error to make right now, sorry. The point is, there's a lack of access and we need to create access, so.
And send an email to Ashley, so I will have, at least have that information for you.
Yeah, I don't understand why this would hold. Send it up. That's why I say it doesn't matter to me.
If it passed the Senate 27-3, why would you think it would get held up in the Senate?
I think there's some politics involved in this, Chair Black.
Yes, but it can't.
There's a lot of politics in
I want
there.
to remind everybody what happens when a bill moves that's been amended and it goes onto the calendar. It doesn't get referred to a committee, so it doesn't go onto a wall. It goes on the calendar on notice, and then the next day it comes up for a vote.
It doesn't have time to go back to the Senate.
How does it not have time to go back to the Senate?
It's gotta go to GovOps and
Oh,
Means and ways.
Means and Ways and appropriations. That's gonna take, they're gonna want testimony. We need this bill today.
How,
kill the biometrics stuff?
how are we gonna get, it's just because we're amending 197, 189, and 190. How are 187, 189, and 190 going to?
Probably not going to.
Well, because some of those are studies that aren't gonna be come into play as soon as this one will. And we can get this out of committee. And if we need to go to AHS or the executive branch to change the state plan, we can do that. Just going through the legislature, it's just another layer and another step that will slow this down and not get this out of committee.
Jen, can Medicaid add coverage for new things on their own? Or,
Yes, we can. They just turn the code on.
Like if I have to defer to Ashley or to AHS, I don't know how they make their coverage. I don't know what's involved in making coverage decisions. I mean, yes, there are certainly some things that they do because, Clinical Utilization Review Board recommends it to the commissioner and they make modifications. But I don't know how new coverage gets added. I don't know if others have direct experience with that.
right,
yeah, I was thinking more about it, and I want to acknowledge the chair's point that the way the process works, it would go to the Senate, the committee would weigh in on it, but I think to the member from Beecham, no. I can't remember your town. Wallingford. Waterford, my bad. Deb, I was trying to like not be so casual. To your point, though, this is, I'm surprised how politicized this bill is out of all the bills. And like that, there's such a concerted effort, like a constant effort to stop it. So like, I can see why you're worried because every stop, every additional stop is another point at which something go wrong. And so I just want to acknowledge that, but I do think Alyssa's right that if that wasn't the case, this could, like, when we send those other bills over, if we don't do anything too controversial, it'll happen quickly at this point. Or it'll come back to us quickly with an amendment, or there'll be a conference committee, you know, so, and that we do have at least 2 weeks left. I know the speaker's trying to end by the 15th, but I would be shocked if we ended by the 15th. I hope we're out by Memorial Day. So I don't think, I'm being honest, like, the governor threatening to veto the budget and all that, I've seen this before, it holds us up. So I say that because I don't think the urgency is as bad as it feels, but I think the politicization of it makes it harder because it's like every day, it's like another dramatic email, you know, so I can see why you're worrying if you want your constituents to have this. So I just want to honor that. But the more I think about it, I don't think there's the urgency I was feeling a second ago, because you're right. So I'm torn. I can go either way. Like I could pass it as it is, or I could pass it with the amendment.
I support the bill as it came to us. I've literally counted emails. And I've done that on one other bill where I had to count emails because I feel like I need to be accountable to my colleagues and I need to be accountable to my constituents for the way that I vote. And when it came down to it on this one, I went by the numbers because we heard incredibly compelling testimony on both sides. And I'm not gonna weigh in on a clinical opinion. Like I'm gonna listen to the experts and they both had equally convincing points. So I went to the numbers and I support the bill as it came from the Senate. And if putting this amendment on it is gonna stop it, I'm very confused. I don't know why it would, because Medicaid coverage is something that I want for every piece of care. I think parity is very, very important in this state, and I think especially to our policies behind us. But in the timeline of everything, I don't understand. I would follow the chair's lead on the urgency of timeliness and whatnot, because the process is still not, I can't wrap my brain around it all, but anyway, I don't have a problem with this bill. I support passing it. And we do not need legislative action to add this to a state plan amendment. I know that. I've worked with the Medicaid office. I used to work at AHS. We don't need it. And if anything has changed since my time there, which is entirely possible, then we won't have Medicaid coverage for a while and we can add it later. But I think to be responsible to my constituents and to my colleagues sitting around this table who I know want this bill for their folks, I'm fine to vote it out of here and move on to the next bills that are frankly a little more impactful.
Well, I will tell you, it is 4:32 and I am now two minutes late for a meeting. We're going to 4:30. We will vote on this at 9 a.m. tomorrow morning.
Give or take a minute.
Okay. And as I said,
Wait for me if I'm okay.
GovOps is already starting their testimony on this. The Ways and Means and approach know that it's coming to them. Everybody's waiting for it to come to them. So we'll vote on it tomorrow morning. So
All right.
we're gonna end committee now. We can go.